the pain. Today we are dealing with how we are managing the pain. Okay. Today we are discussing the topics under the headings. That is, first one is basics of WHO analgesic ladder, step one and step two drugs, and with adjuvant drugs. Okay. This is the WHO analgesic ladder. I think the previous class you already seen this ladder, because in our palliative care we are commonly dealing with the pain management. So that is for mainly for both cancer and for non-cancer pain. So according to the WHO analgesic ladder, it has a two steps: step one, step two, and step three. And in step one, this mainly for the pain, for it's for mild pain. That is mainly include non-opioid with or without adjuvants. If the patient has pain with mild to moderate in intensity, we are considering the step two drugs. It include a non-opioid with or without adjuvant, and the main drug is the opioid. That is opioid for mild to moderate pain. That is, they are known as weak opioids. So we are more detailing evaluated the step one, step two drugs. The next class there will be on opioids. That is mainly for the opioid for moderate to severe intensity. That is another category. That is step three. This is more detail about WHO analgesic ladder. What is WHO analgesic ladder? It is mainly based on the recommendation of a group of international experts that usually come in practice in 1986. It is translated into a 22 languages, which catalyzed for the treating cancer pain in the worldwide. So there are so many international eminence who sit and discuss and come into action that there is a ladder which is mainly for the pain management. So it is a simple one, and it is a very effective, and it is well validated. So here we are just giving that if the in a normal setting, usually if the patient is coming with pain, we are just giving analgesics. So here we have an stepwise approach to treating the cancer pain. That is depending upon the severity. So I think during the earlier class you just studied how we assess the pain. What are the steps to assess the pain? That is mainly that is there is a one PQRST assessment, that is any palliative factors or any aggravating factors. What is the duration of the pain? What is the pain score of the pain? How the intensity? What is the quality of the pain? So depending upon this intensity, we are giving a stepwise approach to treating that mainly for the cancer pain. And in the earlier, before coming this analgesic ladder, the patients are dying with unnecessary pain. So after this WHO analgesic ladder coming, there is patients has more pain relief with this stepwise approach. So among this healthcare professionals, they have a stigma with associated with by prescribing and taking the opioids. So there's the doctors is very afraid to prescribing opioids. Now, after coming this WHO analgesic ladder, the approach become legitimize the use of the opioids, and the patient become free of pain after this WHO analgesic ladder. So, for the sake of the healthcare professionals, it is very simple, and it is well validated to use, and it is more comfortable and giving pain relief to the patients. According to the WHO method, this it can be summarized as a 5 phrases, because we are giving before giving this analgesics, we have something in our mind, that is, if we are giving any analgesics, it is by the clock, by the mouth, by the ladder, and for the individual, and it is attention in detail. In the coming slides, we can discuss the every headings in detail. So you have to just keep in your mind that it is the by the mouth, by the clock, by the ladder, for the individual, and its attention in detail. This is the silent features of our WHO ladder. What is by the mouth? Because the most preferred or the standard route is oral route, even for the strong opioids. What is the name of strong opioids? Anybody know what is the strong opioids? You can text. Any examples for strong opioids? Yes, tab morphine. Good. Anything else? Yes, morphine is correct. Oxycodone. Not other than morphine. Fentanyl. Good. Fentanyl is good. Morphine, fentanyl, and one more drug is there, methadone. These are the strong opioids. We are usually, I think, the next class, pain management of the part two, there you are dealing with the strong opioids. So the most preferred route for our standard route is oral route. So it is very useful and very suitable for the home care use also. So that is why we are most of the patients they say the if we have pain or some patients are complaining of pain, the only working route is injections or IM injection or IV injection or subcutaneous injection. It is wrong. This most common and the standard and preferred route is oral route. Next one is by the ladder. By the ladder, we already discussed. It is a stepwise approach. That is, the stepwise approaches is depending upon the severity or intensity of the pain. So, the start from step one according to the severity of pain, and then it move up. If a patient is coming with some moderate intensity of pain, with a pain score of maybe 5 to 7 or 5 to 6, then we are just starting with the step two ladder. The patient has only mild pain, then we can start as step one. If the patient has a 10 by 10 with a severe pain, we can start as step three. There's a stepwise approaches is there, but depending upon the severity, we can start with step two or step three. If the patient is very severe pain, we can start with the step three also. Next one is by the clock. By the clock means if the patient has a continuous pain, the patient needs the round clock analgesics according to the duration of action of the drug. Because the each drug have different duration of action. Because if is one example, if the morphine has an duration of action of 4 hours. So we are while we prescribing morphine, we are just giving as a fourth hourly. If the 5 mg morphine is fourth hourly or 10 mg morphine fourth hourly, because the duration of action means the amount of medicine in our plasma or in the blood is for only 4 hours. After that, the concentration level will be increased. The patient has again pain may patient has complaint of pain. So just while prescribing medicines, we just give the medicine as a round the clock. Then only the patient has adequate pain relief. That is the third one. The fourth one is individualized to the patient. That means the right dose is one which relieves the pain. That is mainly, usually we are just giving in the medicines. Most of the medicines are we are giving according to the body weight of the patient. If the patient is weight 60 kg, or if the patient has 20 kg weight. So the depending upon the weight of the patient, the need of the medicine concentration or the dose of the medicine is also different. So that is also very important while we are giving or prescribing medicines analgesics. And also, we are just giving and titrate the dose till the pain relief is achieved. And the treatment of breakthrough pain also should be specified. So, if we are giving the medicine, it be given as an individualized. And another thing is one is weight. The another thing is if the patient has some any chronic disease, if the patient has some renal disease, if the patient has any hepatic disease, the liver disease, then also we have to adjust the dose of the medicine. What is the problem if the patient is giving a normal dose of morphine in patient with a CKD or chronic kidney disease? What happened? What is the main function of the kidney? Anybody else? What is the main function of the kidney?
Elimination of drugs.
Not purification, and not the proper
Elimination of
term
drugs.
purification. Not creation of urine, not filtration. That is good. Sudha is telling good. That is excretion of the medicine. That is via kidney. Where it is the metabolism of the drug, where it is happen, which organ metabolism?
Liver.
Yes, good, very good. Liver.
Liver.
So if the patient has any kidney disease, then if we are giving the morphine, so the duration of action is 4 hours. So if the patient has any CKD or any kidney diseases, the excretion of the medicine will be affected. So the concentration of the medicine in our body become more. So they become patient become toxic due to that medicine. The toxicity of the medicine will increase. So in the case of in liver disease or CKD patients, the dose should be adjusted accordingly. So that should be kept in your mind. That is the main thing, that individualized to the patient. It is not same for all patients. It is individualized to the patient. Next is use of adjuvant drugs. That is, these are added at every step for specific types of pain and to decrease the undesirable side effect of the analgesics. Because I think in the coming slides, we are discussing more detail about the adjuvant drugs. Next one is attention to detail. That is the patient age, body habit, comorbidities, drug interaction, side effects profile of the drug meticulously monitored. This everything should be, you should be in your mind before giving it or before prescribing the medicines. And the history of drug allergy or any other anaphylactic reactions also very important before starting these medicines. These are the silent features of WHO analgesic ladder. So first one is the oral route. It is the preferred for all analgesics, including morphine. That is very important. It is the preferred for all analgesics, including the strong opioid like morphine. For persistent pain, analgesics should be taken at a regular interval, not as needed. That is, we are giving as a round the clock. Not the patient is, if the patient has a pain, we're just telling that you taken as an SOS or rescue doses. That is not need. That is not necessary. The patient should be taken as a regular interval for a persistent pain. And the advantages of this WHO analgesic ladder is, one is simple. It is a simple ladder and it is very easy to study, and we can come into action. And it is very effective and it is a universally accepted one. That is very important. It is a universally accepted one and it can be used for both cancer and non-cancer. It is not only for cancer patients. It is can be used for non-cancer pain also, and it is well suited for home care because the most of the medicines are preferred as an oral route, so it is well suited for home care also. I think this slide you can everybody know how we assess the pain, because there is one, we have one what criteria, that is PQRST. That is P. It is the palliative, any palliative or relieving factors, that what makes the pain worse or what makes the pain better. Usually, the patients coming with the pain, they said maybe walking will may provoke the pain, or the when we can give some massages over that pain area that will relieve the pain, or some medications will relieve the pain. That is what is palliative and relieving factors. Then what is the quality of pain? It's very important to know what is the quality of pain, because how would you describe the pain? What does it patient feel or patient tells like? That is, some patient says the pain is what it is a shooting like, and it is a burning type of pain, or it is a very aching type of pain, it is a pricking type of pain. So depending upon the type or quality of pain, the pain types of the pain is different, or it is a neuropathic one, or it is other any somatic pain or any visceral pain. So it is very important to identify what is the quality of pain. The next one is what is the radiation. If the patient has complaints of the pain is starting from one side and it will be radiating to the another side, so that is also very important to identify any radiation factor is there for the pain. And next one is site and severity. That is, where is your pain? The patient has pain in the shoulder, or patient has abdominal pain, or the lumbar pain, or back pain, or pain over the both lower limbs. So where is the site of the pain? And next is severity. Severity, how we assess the severity? We have so many scales is there to assess the severity, and usually we just telling the pain score, that is from 0 to 10. Some of the patients they tell, doctor, I have a pain score of 5/10 or 6/10 or 10/10. So we have to tell the what where is your pain and what is the pain score of the pain score. Next one is timing. Timing and treatment history. That is also very important. Is when did the pain start? How often did you get it? What is the pattern? That it is a continuous pain, or it is an intermittent one, or it is any temporal factor. That is, some patients tell, doctor, my pain is more during night, or more during early morning, or more during evening. So the temporal and timing factors is also very important. Next, this is the assessment of the pain. I think you know what it is. Is it a nociceptive or neuropathic pain? You have to identify. That is, with the quality of pain, we can assess. It is a nociceptive of neuropathic pain. Why we have to address or assessment to differentiate the nociceptive and neuropathic pain? Because the management part is very different for the nociceptive and neuropathic pain. So you have to understand it, whether it is a nociceptive or neuropathic. What is nociceptive pain? It is a pain sensation resulting from injury of tissues. Usually it is a somatic and it is a visceral thing. That is somatic pain and visceral. That somatic pain, it is a localized or intense pain that is described as a sharp, aching and throbbing type of pain, usually accompanied by the local muscle guarding and rigidity. So that is the nociceptive pain. And the next one is it is a neuropathic pain. It is usually results from nerve damages. That is mainly patient presenting with diabetes or chemotherapy. So these patients usually presenting with neuropathic pain. In these cases, the neuropathic pain they are what they're telling us it is a shooting pain. Oh, this is a lancinating pain. This is a burning type of pain. So these are the words they are describing the type of neuropathic pain. These are the scales you have to know how we assess the pain severity. That is, usually for the verbal we have unidimensional scales. That is, one is numerical rating scale, next one is visual analog scale, and next is categorical. In numerical, we are just saying it is from 0 to 10. Patient says 0 is there is patient has no pain. That is 0. While increasing the 1, 2, 3, the patient has pain is increasing, and the number 10 is the worst possible pain in our life. So, what is the possible score for your pain? That some patient says, I have doctor, I have 5 by 10 or 7 by 10 or 10 by 10 score. Some patients they are not able to tell the numbers. So that time we just ask, it is a mild pain or it is whether it is moderate, whether it is a severe. So accordingly, we can start the step 1 or step 2 or step 3. And some non-verbal classification is there. That is one thing is von Bucker Faces scale. In the next slide, I will show the picture. And particularly for the children, the flag, that is the name of the that assessment scale. And for the dementia patients, that is usually we are using Painard scale. And for the elderly patients, usually Dollar Plus. Here, we are most commonly using is the numerical rating scale and the von Bucker's face scale. For the examination point of view, these scales are very important. So you have to study well for this classification. The first one is the von Bucker's faces pain rating scale. That is depending upon this facial expressions, we can classify the pain score. That is 0, 2, 4, 6, 8, 10. And the first one is numerical. That is 0 to 10. No pain, moderate pain, and the worst pain. These are the different types of pain rating scales. So you have to study that von Bucker's faces. That is very important. This is the same thing that is the WH analgesic ladder. That is the for the mild pain, mild to moderate pain, and the moderate to severe pain. Step 1, step 2, step 3. In the step 1, we include non-opioid with or without adjuvant drugs. In the step 2, there is weak opioids or the opioids for mild to moderate pain with or without a non-opioid, with or without adjuvant drugs. And in the step 3, there is a strong opioids with or without non-opioid and adjuvant drugs. So we can combine 1 and 2 and 1 and 3, but not to 2 and 3. We cannot combine 2 and 3 steps. That is very, very, very important. We can combine step 1 and 2, 1 and 3. Not combine the 2 and 3. So because do not give weak opioids and strong opioids together. That is very important. The what are the medicines included in the weak opioids we can discuss later. You should not give weak opioids and strong opioids together. That is very important. This is the step one drugs. We are just dealing with non-opioids with or without adjuvant drugs. So in the step one drugs, it is mainly for the mild pain. Usually we are using NSAIDs for the step one drugs. So we can combine this NSAIDs with an adjuvant drugs. What is NSAIDs? What is NSAIDs? What is the full form of NSAID? NSAID.
Non-steroid inflammatory.
Yes, good. Yes, that is correct. Non-steroid anti-inflammatory drugs, that is NSAIDs. These are heterogeneous group of drugs which produce their analgesic effect through the inhibition of one or both isoenzymes of cyclooxygenase COX-1 and COX-2. We have isoenzymes of cyclooxygenase. That is, first one is COX-1, second one is COX-2. So by the inhibition of these enzymes, we have an analgesic effect. So this is a heterogeneous group of medicines, not a homogeneous. It is a heterogeneous group of medicines by the inhibition of these COX-1 or COX-2. Some medicines will inhibit both COX-1 and COX-2. Some medicines are there particularly selective for the COX-2. So depending upon the inhibition of these enzymes, they are again classified into two. That will be coming in the coming slides. So the important enzyme in the arachidonic acid cascade, which produces the tissue and the inflammatory prostaglandins, are these cyclooxygenase enzymes. So these prostaglandins mediate pain through the peripheral sensitization and amplifies the pain sensitized nerve endings, and it will lower the threshold of response to pain stimulus. So usually the nociceptive pain will be associated with the inflammation. So in that case, if the patient has a nociceptive pain, the NSAIDs will more effective than what under neuropathic agents or under weak opioids. So that's why we are just understand whether the patient has a nociceptive pain or a neuropathic pain. This is COX-1. Usually, this COX-1 enzyme is present in all normal tissues, especially in our GI tract, platelets, and kidney. So these are the normal site of this COX-1 enzyme. So this is a constitute or the housekeeping enzyme which mediates the physiological response. It will protect the stomach and kidney and facilitate the platelet aggregation. These are the what actions or the mechanism of action of this COX-1. This is usually seen in GI tract, platelet, and kidney. In the platelets, they helps in platelet aggregation. In the GI tract and kidney, they will protect the stomach and kidneys. That is the action. Next one is COX-2. It is an inducible enzyme. So it is usually occurs when there is an inflammation. When any inflammation in our body, the COX-2 inhibitors become inducible, and it present in constantly in lungs, brain, kidney, and testes. These are the main what site where the COX-2 enzymes are seen. So it usually mediates the prostacyclin synthesis via vasodilatation, inhibition of the platelet aggregation. This is the mechanism of action of COX-2. Next one is a non-selective. We just discussed what is COX-2, where it is seen, what is the mechanism of action, and what is this COX-2 enzyme. It is an inducible one, where it is seen, and what is the mechanism of action. Next, we are seeing non-selective COX inhibitors. This is classification under NSAIDs. This is the first classification under NSAIDs, that is non-selective. The word or the term which what presents, that is, it blocks both COX-1 and COX-2. It is a non-selective one. So it is inhibit both COX-1 and COX-2. So the main examples which are dealing with this non-selective COX inhibitors are ibuprofen, naproxen, aspirin, piroxicam, mefenamic acid, and ketorolac. These medicines are commonly used in our day-to-day life. So it is very important to know these medicines are coming under non-selective COX-2 inhibitors. First one is brufen, naproxen, aspirin, piroxicam, mefenamic acid, and ketorolac. Next. This is the mechanism of action of non-selective, how it acts. So, I already told that it has an inhibition to COX-1 and COX-2. So, depending upon the inhibition action, it has a beneficial effect and also it has side effects. So, the side effect of this non-selective NSAID is by the action of inhibition by COX-1 derived prostanoids. That will result in the adverse effects. By the inhibition of this COX-2 derived prostanoids will result in beneficial effects. So this is the mechanism of action of non-selective NSAIDs. Explain once more because it is a little bit confusing. The non-selective NSAIDs has inhibition of COX-1 and COX-2. The inhibition of COX-1 results in adverse effects. What are the adverse effects? The most common adverse effect is GI side effects, that is bleeding, then hypersensitivity, angioedema, arterial lesions, bronchospasm, and renal side effects. These are the main side effects of NSAIDs. What are the non-selective NSAIDs? Examples for non-selective NSAIDs? Anyone tell?
Brufen,
Yes.
aspirin,
Yes.
mefenamic acid,
Yes.
ketorolac.
Okay. Last one. Brufen, mefenamic acid.
Ketorolac.
Yes.
Aspirin.
Aspirin, piroxicam. Yes, good, very good. So, other side effect is by the inhibition of COX-1. And the next is beneficial effects. Beneficial effects means the benefits of this NSAID is one is its anti-inflammatory action, another thing is analgesic effect, and the next one is antipyretic. This is the three important mechanism of what beneficial effects of this NSAID is. We are usually using this NSAID is for anti-inflammatory, analgesic effect, and for antipyretic. So that is by the inhibition of COX-2. That is very important to know how we giving this beneficial effect by the mechanism of action and the mechanism of action of the adverse effects. These are the side effects, the common side effects of NSAIDs. That is usually non-selective NSAIDs. First one is renal. Next one is sodium and water retention, acute and chronic renal failure, and GI side effects is bleeding, ulcerations. And the fourth one is hypersensitivity. That is respiratory, that's bronchospasm, and some anaphylactic reactions to the skin, and also generalized anaphylaxis. These are the hypersensitivity reactions. Next classification, that is selective COX-2 inhibitors. So in NSAIDs, we have two classification. One is non-selective inhibitors, and the second one is selective COX-2. That is by the name itself, it says it is only inhibiting COX-2. That is the selective COX-2 inhibitors. It only inhibit COX-2. The examples of selective COX-2 inhibitors are celecoxib, rofecoxib, valdecoxib, parecoxib, etoricoxib, lumaricoxib, and diclofenac. So I think we are commonly using this diclofenac, etoricoxib. They are the most common we using these drugs. So you have to know how it acts. What is the mechanism of action for this selective COX-2 inhibitors? These are the risk factors for GI toxicity while we using these COX-2 inhibitors. That is, if the patient has an advanced age and if the patient has high and prolonged use of NSAIDs and history of any GI symptoms or any peptic ulcer or any bleeding history or concurrent use of this aspirin, steroids, anticoagulants, in these patients, the GI toxicity of these medicines is very high. So you have to keep in mind these criteria or these points before starting NSAIDs because this will increase more GI toxicity. The next thing is renal toxicity. That is, this is the things you have to know that if the patient is dehydrated, or there is concurrent use of any other nephrotoxic drugs along with NSAIDs or beta blockers along with NSAIDs, and the patient has an advanced age, poor diabetic control, while using any AC inhibitors or any diuretics, and if the patient has a creatinine clearance less than 30 ml per minute, these if the patient has these points or these symptoms, if the risk of renal toxicity while we using NSAIDs is very high. So before starting NSAIDs, you just check the patient. If the patient have taking any other nephrotoxic drugs or any beta blocking agents or AC inhibitors or diuretics, or patient has any kidney disease with creatinine clearance less than 30 ml, or what is the age of the patient, if the patient is dehydrated or not, and the patient is taking what is the glycemic control of the patient. Everything is very important before starting NSAIDs to decrease the renal toxicity. These are the risk factors for stroke or MI. So, the common side effects of the non-selective COX inhibitors is, first one is GI toxicity, next one is renal toxicity, the third one is stroke or MI. MI means what? What is MI?
Myocardial infarction.
Yes, very good. Myocardial infarction. Yeah. So, if the patient has an advanced age, diabetes, hypertension, hyperlipidemia, smoking history, and the use of any COX-2 drugs, in these patients, the risk of stroke or myocardial infarction is very high. So, we have to be very cautious to use NSAIDs in these patients. We can use for a short duration, not for a prolonged use. Here in this slide, we are discussing these are selective COX-2 inhibitors safe as compared to non-selective. Which is more safe? Is a non-selective one or selective COX? Which is more safe? So it is safe for GIT as compared to non-selective NSAIDs. The selective COX-2 inhibitors are safe for GIT. And it is more safe for renal damage. It is comparable with non-selective NSAIDs. And the thrombotic events are more likelihood of MI and in stroke while we using non-selective. And for the selective COX-2 inhibitors, that is like ropicoxib, which was taken off from the market in 2004 because of its side effects. So selective COX-2 inhibitors are safe for GIT, and renal damage, it is comparable with non-selective NSAIDs, it is less renal damage. So, and the prothrombotic, there is more likelihood for MI and stroke. So this point is very important. So the lowest effective dose should be used for the shortest duration required to control the symptoms. And the need for ongoing treatment should be reviewed regularly. This is very important while we prescribing NSAIDs. The lowest effective dose should be used for shortest duration to control the symptoms, and we have to regularly review the ongoing treatment. Otherwise, it may cause renal damage, GA toxicity, or there is a chance of stroke and myocardial infarction. So you have to be in regularly. Patient should be in our follow while we using this NSAIDs. These are the precautions with NSAIDs. That is, before we are giving NSAIDs, you should be administered with the gastroprotective drugs like proton pump inhibitors. The next one is cautious use in patients with peptic disease or advanced age, or the patients with smokers, alcoholics, steroids, hypertension, asthma, renal dysfunction, gout. In these patients, you should be cautious while using NSAIDs. And it should be avoided in bleeding tendency or with the anticoagulations. And for the COX-2 selective inhibitor should be contraindicated in atherosclerotic disease, CAD and CVA. That is very important. These COX-2 selective inhibitors are contraindicated in atherosclerotic diseases like CAD and CVA. And advise the patient to take plenty of oral fluids while taking NSAIDs. That is also very important. Next thing is paracetamol. I think everybody's know more than paracetamol, more about paracetamol, because this is we are commonly using in our day-to-day practice the paracetamol, because if any patients have any complaints of pain, we just give you just to take paracetamol. So we have to know more about paracetamol. It is an acetaminophen. It is predominant central action by inhibiting the enzyme cyclooxygenase in the CNS. It has no effect in the peripheral cortex. It is only the paracetamol has only central action with the cyclooxygenase, no action in the periphery. So the side effect of the paracetamol is very less. And it has an antipyretic and analgesic action. There is no anti-inflammatory action. So that is very important. By discussing with NSAIDs, we just said that it has an anti-inflammatory, analgesics, and antipyretic action. That is for mainly for the selective COX-2. That is for the non-selective inhibitors. Here, the paracetamol, there is no anti-inflammatory action. It is only antipyretic and analgesic effect. This is the dose, safest dose and the maximum dose we can given for the paracetamol. The safe dose is 12 to 25 milligram per kg 6th hourly, and the daily dose should be less than 4 mg. That's we can give 1 gram as a 6th hourly maximum. That is 4 gram per day, is daily dose, and the single dose should be less than 1 gram, and the potential for hepatic toxicity is very high. So, but it can be safe for using paracetamol in liver disease up to 2 to 3 gram. The normal dose should be 4 gram per day for paracetamol. If the patient has a liver disease, it can be given. Some says there is a contraindicated in liver disease for paracetamol. It is not like that. It can be given as a safe up to 2 to 3 gram per day. And the pediatric dose is 50 milligram per kg, and the rectal route also preferred. It is only when the oral route is not feasible, then we can give paracetamol suppositories for the pain and also for the antibiotic action. This is the, I think, the step one drugs we already finished. It includes NSAIDs, that is selective COX-2 inhibitors, and also non-selective, and also paracetamol. These are the step one drugs. Next, we are moving to step two drugs. It includes weak opioids. These are the weak opioids. That is, the examples for weak opioids is codeine, tramadol, tapentadol, and propoxyphene. These are the step two drugs. Is it out? Why we are not administered admin?
Sundravalli, can you tell me what you mean by this message? Why are you not?
Seriously, you have to administer this drug for advanced age, hypertension, asthma, and gout patients. Why gout patients we should not administer them?
Because in these patients, it is a gout is due to the hyperuricemia condition, na? So in that patients also we should be cautious in, but the long term NSAIDs use is very less in these patients because it may cause more damage. There is an inflammation. What?
Damage of what, ma'am? GI tract.
No, not GI. Gout is what? What is gout?
Increased uric acid level.
So because of that, what the patient may came with what complaints?
Pain in the joints.
Yes. So there's a severe anti-inflammatory is there.
Yes,
so okay. So that cases it is not a contraindicated. It should be cautious. Do not give this NSAIDs for the long time. Long term management is not possible in gout. So in that cases, we have some modified medicines like this particular medicines we are giving for the gout. Now I didn't remember the name for that medicine. So at that time, we should be cautious, not a contraindicate, not an absolute contraindication, cannot use for the long-term purpose for. Because if the patient presenting with gout, we are just giving only for, not for a symptomatic treatment there. Can give the particular curative treatment is possible in gout. So if some patients were just buying analgesics from the pharmacy and they are taking it. So that is not advisable. So that should be very cautious, not a contraindicated.
Okay, ma'am. Thank
you. Okay, next we are dealing more about tramadol. I think this medicine is also we are commonly using in our day-to-day practice. So the mechanism of action of this tramadol is it is a centrally acting drug. It's a synthetic weak opioid, and the mode of action is dual. So it has action on two receptors. That is, one is mu opioid receptor agonist. That's why it is a weak opioid. And the next, it will block presynaptic reuptake of serotonin and non-epinephrine descending inhibitory pathways. This is the mechanism of action of this tramadol. So this combination of tramadol and paracetamol can be used as a step 2 drug. And the main advantage of this tramadol it has some neuropathic component. So it can be used for neuropathic pain also. This is one advantage of this tramadol. You keep in mind that it has some neuropathic component and it has usefully giving neuropathic pain relief also. And the mechanism of action is also very important. It has a dual mode of action on the mu opioid receptors, and also it will block the presynaptic reuptake of norepinephrine and the serotonin. It has a high oral bioavailability, and the oral dose potency is 1/5 of the morphine. That is very important. You can get some MCQs like this for what is the oral dose potency of tramadol. So it is 1/5 of the morphine. And the IV dose potency is 1/10, and is the equivalent dose of this tramadol means 400 milligram of tramadol is equivalent to 40 to 80 milligram of morphine. If the patient is taking, maybe usually we prescribing tramadol as a 50 milligram TDS or 6 hourly or 100. If the patient has obese or more weight, we are giving 100 mg 6 hourly. So that 400 milligram of tramadol is equivalent to 40 to 80 milligram of morphine. That is the equivalency of tramadol and morphine. And usually we prescribing as 50 to 100 milligram every 4 to 6 hours. Usually we are prescribing as a 6th hourly, not more than 4 hours. Usually we are giving 6th hourly. The maximum daily dose is 400 milligram. That is 100 milligram 6th hourly for 4 times a day. That is the maximum dose. One more thing. What are the common side effects while we are expecting, while we giving tramadol?
Vomiting.
What? Not clear.
Vomiting.
Vomiting. Very good, very good, very good. Vomiting. Next one.
Drowsiness.
Not clear.
Drowsiness.
Yes, some patients have drowsiness. One more common side effect is also there with the tramadol. The most common and important one is vomiting. Yes, somebody says.
Constipation.
Yes, very good. Constipation. Yes, constipation. So, if you before you prescribing tramadol, your prescription should have an antiemetic and also an laxative. So, if the patient prescribing or starting tramadol, we are just giving an antiemetic. We are usually giving metoclopramide here. And the next one is a stimulant laxative, that is bisacodyne. Bisacodyne 5 mg 2 Hs. This is the normal prescription while we, this is the complete prescription while giving tramadol. Antiemetic, a laxative, and then tramadol. That is very important. Next drug is tapentadol. It is similar to tramadol only. It has also dual mode of action. This is a mu receptor agonist, and it has inhibitory pain pathways preventing the uptake of the serotonin and norepinephrine. And it is available as tablet in strength similar to the tramadol. Same, that is 50 to 100. And it can be given as 50 to 150 milligram 6th hourly up to 400 milligram per day. That is most of this medicine is similar to the tramadol. But it is less commonly we are using this tapentadol. More commonly we are using tramadol. Next one is codeine. It is 1/10 potent as morphine, and the main metabolite of the codeine is codeine 6-glucuronic CYP2D D6. This is the main metabolite. The mode of action or the mechanism of action is to this main metabolite, and it is a prodrug of morphine. So if we are asking the one example for the prodrug of morphine, we say it is a codeine. And the onset of action is 30 to 60 minutes. That means if we are giving a codeine, the action will take after 30 to 60 minutes, and it will be in our blood, or the concentration of the medicine in our blood for 4 to 6 hours. So we can give as a 6th hourly or 4th hourly. It is mainly for pain relief, cough suppressant, and for antidiarrhea. But I think now it is less commonly we are using this codeine because of our side effects. This is the side effects, common side effects of all these step 2 drugs. That is, first one is nausea, next one is vomiting, dizziness, drowsiness, hallucinations, and confusion. Next important thing you should be in your mind is seizure may occur with the use and they appear to be most likely in people taking drugs that lower the seizure threshold or who have history of seizure. So before you prescribing the tramadol, you have to keep in mind that if patient has any history of seizure or the patient has on any anti-epileptic like Levipil or something, it will, if we are giving this tramadol, it will decrease the seizure threshold and the patient may be precipitated with seizure episodes. So if the patient has any seizure history, do not start tramadol. That is very, very important. It will lower the seizure threshold and the patient may present with the seizure episodes, active seizure episodes. So you should be cautious while using tramadol in seizure patients. It is very important. So the past history of the patient is very important while we are starting these medicines. You have to take a detailed history. That is because our medical history, that is patient, what is the non-case, what is any hypertension, CAD, what any GI history, GI bleeding, any CKD. So that is very important with starting any medicines. Next, we are dealing with another topic, that is adjuvant analgesics. So adjuvant analgesics means if a drug or any drug, their primary indication is not an analgesia or not this medicine is not using for any analgesia, but it has some effect or some kind of pain relief it will give. That's why it has an adjuvant analgesics. So any drug that has a primary indication other than pain, but analgesic can happen in some kind of pain relief. So that is very important in these cases. So you should know what are the medicine that should be started in adjuvant analgesia. These are the different types of medicines we are using as an adjuvant analgesics. First one is antidepressants. Next one is anticonvulsants, corticosteroids, bisphosphonates, cannabinoids, ketamine, anesthetics, and neuroepileptics. These are the commonly used medicines for as an adjuvant analgesics. First one is multi-purpose adjuvant analgesics. First group is TCA. What is TCA? What is TCA? TCA. You can see the examples. So you can tell what is TCA. Amitriptyline, which group? Yes, good. Preeti, yes, good. This is tricyclic antidepressants. Very good, very good. Everybody saying. Okay, tricyclic antidepressants. The examples are amitriptyline, imipramine, and non-triptyline. Next one is alpha-2 agonist, that is clonidine. And the third one is corticosteroids. Usually we are using dexamethasone and prednisone. These are the multi-purpose adjuvant analgesics. These drugs are mainly we are using for the neuropathic pain. This is the main mechanism of action of this neuropathic pain. Usually, the dose which is using for analgesia is very less than their actual action mode of action, because if we are using amitriptyline, their dose using for this antidepressant action is more than when compared while using with the analgesic effect. So less dose is usually using for amitriptyline for the analgesic effect. Usually, we are starting this amitriptyline as a 12.5 mg HS. Usually, advise the patients to take at 7 o'clock or 6:30 p.m. because these medicines have an drowsiness or sleepiness during the early morning hours. So, if the patient is taking this medicine during the late night, the patient has complaining of severe drowsiness and sleepiness during the morning time. So advise the patients to take it as at earlier, that is at 7 p.m. or 6:30 p.m. And it has some side effects also. Usually during for the amitriptyline, we are just say the patient has some patients presenting with urinary hesitancy and dry mouths, so excessive drowsiness. So usually for the old age or advanced stage patients, and if the patient has any history of BPH, about benign prostate hypertrophy, that patients we just avoid to start this amitriptyline because the urinary hesitancy, the urinary symptoms will may aggravate. So in these patients, we can consider any other medicines. So for the mainly for the neuropathic pain, the first line medicine is first one is TCS antidepressants. Amitriptyline is the one of the most commonly using amitriptyline medicine. It is mainly for the burning. If the patient complains, say, doctor, I have complaining of burning type of pain. In Malayalam, they say it's this Pogachal, or if anybody is Malayalis, they just said, they said, Mola Karacha Bolatha Vedana. So in English, there's a burning type of pain. So if patient has such kind of pain, we are just starting amitriptyline. And next one is SNRIs. That is the example is duloxetine. Duloxetine is mainly we are using for the diabetic neuropathic pains. The patient has a diabetic neuropathic pain like pains. We are just starting duloxetine. Next group of medicine is anticonvulsants. In this group, we are using gabapentin, pregabalin, carbamazepine, and sodium valproate. The next one is corticosteroids. So, the mechanism of action of this anticonvulsants is it's shared between the epilepsy and pain because the neuronal hyperexcitability will dampens the neuronal excitability. This is the mechanism of action why we are using anticonvulsants in the controlling of analgesia or the action of analgesia by this mechanism. So usually gabapentin we are starting as in 100 mg. Gabapentin we are using 100 mg HS. We can increase as a BD or TDS dose. Maximum we can give as a 300 mg. Usually pregabalin we are starting as a 75 milligram HS. This is the now I am telling the analgesic dose of these medicines, not the actual anticonvulsant dose or antidepressant dose. This is the analgesic effect dose I just try to tell. That is gabapentin is 100 mg as a starting, pregabalin as a 75 mg starting, and sodium valproate usually we are giving as a 200 milligram. Duloxetine is 20 milligram as starting. Amitriptyline is 12.5 mg. We can give us a 25, 35, 37.5. We can increase accordingly after assessing the pain score. And usually we are telling the patients that if we are starting these medicines, these neuropathic or adjuvant analgesics, just wait 4 to 5 days for getting good pain relief. Because the once we are starting these medicines, the actual what onset of action will becomes within 4 to 5 days. So after 4 to 5 days only we can hike the medicine. Otherwise, it did not relieve any pain relief. So the after 4 to 5 days we assess the pain. If he or she has no adequate pain relief, we can hike the dose. That is why we can follow up the pain relief of the patients. Most of these are the contraindications of tricyclic antidepressants because if the patient has a severe cardiac conduction defect or the patient has a history of arrhythmia or patient has an heart failure and the patient has a BPH. I already mentioned that for if we are starting amitriptyline, we are just if patient has a severe BPH, the urinary symptoms will be increased, urinary hesitancy may happen. So it should be contraindicated in TCS. And the patient having narrow angle glaucoma also, we should not use TCS. Some other drugs, that is, we are drugs which are using for adjuvant analgesias are one is oral and parenteral sodium channel blockers, NMDA blockers like ketamine, amantadine, baclofen, and some topical analgesics like local anesthetics, that is lignocaine. And lignocaine injections also we can use. And NSAIDs mainly for the acute musculoskeletal conditions. And the next one is bone pain, mainly for the bone pain. The patient has a carcinoma or malignancy, the patient presenting with multiple metastasis to bone. So in these patients, you have to think of starting bisphosphonates or radiation or steroids, calcitonin. Steroids also plays a very important role yeah, while we giving a patient having bone pain. And because the mechanism of action for starting the steroids is it will decrease the peritumoral edema. For we are starting dexamethasone. Usually the higher dose is 16 or 16, and we're just giving the 60 milligram for 5 or 6 days, and we're just tapering the down the steroids and will stop. And it will decrease the peritoneal edema and it will give better pain relief for the patient. And if the patient presenting with bowel obstruction, it is depending. It is a partial whether it is a partial or it is a complete obstruction. We can start steroids, octreotide. Octreotide means it is a somatostatin analog and it will decrease the secretions. So that's why we are using octreotide. And next one is anticholinergics, mainly hyoscine butyl bromide. That is we are known as buscopan. So buscopan we are using for mainly for the complete bowel obstructions, and glycopyrrolate we are using for decreasing the secretions. The patient in end of life or the patient presenting with some death rattle. I think you have to study these terms in your coming classes. So in that cases, to reduce the respiratory secretions, we can give glycopyrrolate. And this hyoscine butyl bromide we are giving for the complete bowel obstruction. These are the indications for starting steroids. First one is neuropathic pain, bone pain, headache from raised ICP. ICP means intracranial pressure. Arthralgia, bowel obstruction, pain from spine metastasis. Dexamethasone is usually single dose, half-life is 36 to 54 hours. So it is a less mineralocorticoid side effects. That's why we are more preferring dexamethasone. And it can cause insomnia. That is very important while we are prescribing dexamethasone. Advise the patient to give in the morning, not in the afternoon time. That is not because it can cause insomnia, and it should be given along with the proton pump inhibitors. So this is very important. Before starting dexamethasone, you should be advise the patient. It should be given in the morning time, and you can give proton pump inhibitors along with the corticosteroids. Okay, I think this is the topics I completed. That is WHO analgesic ladder, step 1 and step 2 drugs, and adjuvant analgesics. Anybody has any doubts?
Payal, you wanted to say something? If you have any doubts, you can put it on the chat box, or otherwise you can unmute yourself and ask it. We have time. Nobody has any doubts? Preeti Chavari has asked something. When to start paracetamol and when to start tramadol?
I already mentioned the WHO analgesic ladder. So this is in step 1. The step 1 is mainly for the mild pain. In step 1, we usually use non-opioids with or without adjuvant drugs. That is knowing that non-opioid include this paracetamol. If the patient has only mild pain, we can start paracetamol. And if the patient is presenting with moderate intensity of pain, then we can start step 2 drug. The tramadol is coming under step 2 drug. So you can give tramadol and paracetamol together. I already told that we can combine step 1 and step 2 medicines together, but not give step 2 and step 3 together. So depending upon the severity, we can start. If the patient is mild pain only, we can start paracetamol. If the patient is presenting with a moderate intensity of pain, we can start tramadol. You got it, Preeti? Okay.
Anyone else has any doubts? BG? Sia? Okay. If no one has any doubts, we shall move on to the case part of the case. We haven't got any case presentation from you people, so ma'am is going to tell you, present you with 2 cases. Okay, shall we move on to that? Okay, ma'am.
This is one case. I think this patient, this is a 60-year-old male. It's a non-case of hypertension and old case of CVA. And patient was diagnosed with ACS with NSTEMI. Came with complaints of ulcer over the right foot since 2 months. And the patient has complaints of pain and swelling in the right foot since 2 months. And while telling more about the pain is acute in onset. It is in moderate intensity with a pain score of 6/10. And it is an aching and therapy type of pain. And it is aggravated during night. And it has mild relief for 3 to 4 hours with paracetamol. And there is no radiation. This is just telling the pain under the score of PQRST. Okay. What is the palliative factor, relief factor? What is the quality? What is the quality? It's a aching and therapy type of pain. And the intensity is 6/10. The score, that is moderate intensity. And there is aggravator more during the night time. And the relief only for 3 to 4 hours with paracetamol. Usually the patient is taking paracetamol as 500 mg TDS. The patient has only for 3 to 4 hours pain relief. And the ulcer is initially starting as a blood formation. Later, it ruptured with the foul smell discharge. And the patient's sleep is disturbed due to the severe pain. And he also has weakness of the left upper and lower limb due to the CVA episode. And the appetite is okay, adequate bowel and bladder habits. ADLS is with support due to his weakness. And on examinations, conscious oriented vitals is stable, and the ulcer is 10 into 8 centimeter ulcer over the dorsum of right foot with slough present. And patient underwent debridement in a local hospital, and now he is doing daily dressing at home with using Debridase and Metrozole ointment. The diagnosis is infected ulcer with cellulitis, right foot, POVD, systemic hypertension, ischemic heart disease, ACS, NSTEMI, and history of old CVA. These are the medications he is taking. That is tab glimepiride 1 mg BD, metformin 500 mg BD, atorvastatin 20 mg HS, ecosprin, propylate classics, abiphilin, and for the pain he is taking paracetamol 500 mg TDS. These are the psychological issues he is facing. One is emotional pain due to regarding this inadequate pain control, and he is not able to go for any job, and feeling of burden to family. And he also has anger issues. He's very frustrated due to pain, and he has severe financial constraints and burden, and feeling of sad. So while we are studying about the palliative care, this is a total pain approach is very important, because the physical aspect of the patient, not physical, is very important than other emotional, psychological, and spiritual aspect. So that is also we have to address while taking this history or addressing her concerns. So these are also very important. So what next? If the patient presenting with these symptoms, what will you do? This is the history. How will you manage this patient? Anybody? According to WHO analgesic ladder, which step we can start? Yes, ASIA. Yes, very good. Weak opioids. Yes, very good. Very good too. Anything else? Yes, very good. Weak opioids. Which weak opioid we can start? Name of the weak opioid? Paracetamol. Okay, we can combine. That is also very good. We can combine weak opioids plus paracetamol. Yes, tramadol or Reno. Very good. Tramadol. So in this patient is taking paracetamol TDS. So we can hike the paracetamol at 6th hour. 500. A patient has only pain relief for 3 to 4 hours. So we can hike, increase the dose of the paracetamol 500 mg 6th hourly. And we can add tramadol 50 mg 6th hourly. What are the other medicines we can add with this paracetamol and tramadol? What are the other medicines? Prigaba, okay. Ketorolac. Why ketorolac? Sudha, why ketorolac? Yes, Jennifer, good. Adjuvant. Adjuvant can come because there is a type of pain that is purely a neuropathy component is there. So we can add adjuvant analgesics. Maybe Prigaba, gabapentin or amitriptyline. Usually we are starting with the amitriptyline. But why ketorolac, Sudha? Sudha, why ketorolac? This is an NSAID. Dufelac, yes, good. Yes, Dufelac, Priyanka, it's very good. Dufelac or Cremafin we can give. That is a laxative. Usually we are preferring stimulant laxative. That is bisacodyl. You can get classes for more detail about the laxative classifications. Then you can get more why we are giving stimulant laxatives. You can give this Dufelac also. That is also very good. Before starting tramadol, which drug you have to start?
Tablet pan 40.
No, not Pando. Yes. Reno, Emiset and Perinom. This is an anti-emetic medicine. That is very important. And advise the patient to take an anti-emetics before you're just giving this tramadol. That is very, very important because some patients they are took this tramadol after this anti-emetics. So patients with dizziness or vomiting, you should advise the patient clearly that you have to take antiemetics prior to this tramadol. That is 15 to 20 minutes prior to giving tramadol. That usually we are commonly using Perinol. We can give Emset also. That is also okay. So that is very important. So the corrective prescription should be the patient paracetamol 500 mg 6th hourly, tramadol 50 mg 6th hourly, tab metoclopramide 10 mg. We are usually giving for continuously for 3 days. That is Perinom. We are usually giving for 3 days. Then advised to take as an SOS dose. So Perinom 10 mg TDS for 3 days and SOS and tababisacodil 5 mg 2HS. And we can start some adjuvant analgesic like pregabalin or amitriptyline or gabapentin. That is dependence. Everybody should understand this case. Any doubts? Usually, I think there's some anti-emetic reduces the effect of tramadol. Which are they? Not decreasing this what action of tramadol. Usually, this emeset. What is the content of this emeset?
Perinam.
No. What is the content of emeset? Emeset. What is the generic name of this emeset? What is the generic name of perinom?
Aldosterone.
That is ondansetron. That is emeset. Emeset is ondansetron. The perinom is metoclopramide. Perinom is metoclopramide, and the emeset is ondansetron. Got it? Clear?
Yes, ma'am.
Yes, yeah. So this ondansetron can cause decreasing the bowel movements, or it will promote constipation. So while we are giving tramadol and emeset, it may aggravate constipation. So usually we are preferring what? Metoclopramide. Metoclopramide is a prokinetic drug. So it will increase the peristalsis, and it may cause a smooth, satisfactory bowel habit. That is, I think, who told that question in message? Preeti.
Preeti, are you there?
Yes, ma'am.
You clear your doubt?
Clear, ma'am. Clear, ma'am.
Clear. Okay.
Yes, ma'am.
Okay.
Thank you.
Okay. Okay. This is. I think you can clear this. How we start the step 2 drugs. Everybody is clear.
Yes, ma'am.
Okay. Then one more discussion. That is mainly for before starting. You have to before starting this NSAIDs. I already told one slide about that, and you can tell what are the things you have to give instruction to the patient before starting NSAIDs. What are the things? What are the instructions you should give the patients before starting an NSAID? Everybody can tell each points. I think I already told some 4 to 5 points. Before starting NSAIDs, what instructions we have to give to the patient? No instruction?
We went through the whole class, right? Please unmute yourself and
Yes. Plenty of oral foods. That is very important. Very good, Preeti. This next name is Pranali. Yes, that is very good. Plenty of oral fluids. That is very, very important. You just educate the patient to take plenty of oral fluids. ASIA. That is also very important. Very good. That is Pandow. You should be prescribed Pandow along with NSAIDs. That is also very, very important. Oral hygiene. That is okay. That is not much. That is important, but not important before starting this what NSAIDs. First one is plenty of oral food. Then is PPAs. Then ask whether any history of GI bleeding or any kidney diseases. That is also very important. I think I already told one slide. This thing is very important. That is plenty of oral fluids, and you should be at PPAs. And what are the diseases? The past history is very important. And if the patient has any CAD, CVA, or atherosclerotic disease, and should be very cautious while using COX-2 selective inhibitors, and ask for any bleeding tendencies for their patients. And also the some CAD patients, they are already on anticoagulants. So that should be also, we can give, I already tell that we can give the lowest dose for the shortest duration. And the patient is on NSAID, you should be regularly reviewing the medicines and the treatment. For the long-term use, the NSAID is not prescribable. That is very, very important because it can cause renal toxicity, GI toxicity, and also stroke and MI. So it is very important while using the NSAIDs for a long-term use. That is the main thing you should be in your mind while using NSAIDs. I think do not pressure in motion passing. That is that what Priyanka? I didn't get you that.
Ma'am, bleeding present, that's why.
Yes.
Don't-
Any constipation? You. That is all. You're telling that is constipation or
Oh.
don't. I didn't get you.
Ma'am, pressure, don't pressure in motion timing because
That
of
is
ears present.
bleeding.
Canal side.
Chances of bleeding is there. That's why you are
Yes.
telling that.
Yes, ma'am, yes.
Yes. Okay. That is also okay. I think it is over. They are almost everybody is very interactive, and thanking you to listening me for the past 1.5 hours, and thank you all.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
If you have any doubts, you can ask. We still have time. Anybody has any doubts? Okay, shall we wind up? Before winding up, I need to tell you something. Don't forget to put your feedbacks. I will put a link for your responses. We need your feedback actually. We are getting only fewer responses only. So please don't forget to comment on the comment through the feedback form. Okay. On each and every sessions you have to do that. Okay, I'm first of all I'm thanking Dr. Susan John for the wonderful session she has taken today, and I thank all the participants because it was very interactive. Susan ma'am herself is very impressed about you. So we'll see you in the next session. Okay, bye.